It's really a pleasure to come and speak with you guys today. I always learn something not only from the other speakers, but just from spending time with patients. It's really quite valuable to us as physicians. So I'm just going to touch briefly on the topic of shared decision-making using an example from our own pediatric experience. And this is something that's been flavored throughout some of the discussions already this morning, but just to give it some more context. So when we think about treatment options, we've kind of covered first-line therapies, and then sort of we get into this other box of second/third, where do we go from there? And as you've seen, there's a lot of discussion points around this, right? There's no one clear path for any one patient. This is our 2019 guidelines from the American Society of Hematology. And as you can see, there's a lot of suggestions. This is for pediatric patients requiring a second-line therapy. But these are all suggestions. Nothing is hard and fast. Nothing is set in stone. There were a lot of caveats around this. There was a lot of information we felt we didn't have that we wanted in order to make a more firm decision about how to guide patients and medication selection. And so what we ended up with were conditional recommendations. And what does this mean? What does it mean to have conditional recommendations or suggestions as opposed to a true recommendation? And what this really means is that for patients, a majority of patients may want that intervention, but some may not. And for clinicians, it means that different choices will be appropriate for different patients, depending on values and preferences, and there's a strong need for the use of shared decision-making. There's also a strong push from this. I think when we see a lot of conditional recommendations, there's always an area to make our research strategies better. So as we've touched on, trying to gather things like health-related quality of life, fatigue data, bleeding data, things that matter to patients besides just the platelet count, to really help us have the evidence to formulate decision-making. So this was a pediatric trial that we did. This is the Pediatric ITP Consortium from North America, or ICON. And we looked at pediatric patients with refractory ITP who were starting a second-line therapy. And we asked the physician to sort of rank the top 3 reasons that the particular drug or particular pathway was selected for that patient. And this just shows you here a breakdown of sort of what different agents were used. So about a third got rituximab, another third ended up on a TPO. We did actually have some children with splenectomy, and then we have kind of a mix of some other immunosuppressive therapies that we kind of grouped together because there was no one that was great enough in number to look at individually. But what we saw, this is the reason for selecting the particular drug. And again, this is the physician's perspective, right? I think one thing we missed out on doing was actually asking the patient if they agreed with what the physician was thinking. But in 55% of the time, this decision involved parental or patient preference. And we talked about this with rituximab even earlier too, as an example. 18% of the time it was selected as the number one reason. Only 9% of the time was there a reliance on published guidelines or recommendations, again, likely because of the fact that they're not very evidence-based, and there is a large dependence even in guidelines on patient preference, and we recognize that, the absence and gaps that we have. So this just highlights a big need, right? We are feeling as though we are relying on patient preference, but are we really doing that in clinical practice, or is that just our impression? So how can we understand patient and parent preference if it matters so much in our decision-making and we're so reliant upon it? So we have to move beyond guidelines, right? We have guidelines. I think they can formulate a background. They tell us what's out there. They tell us what we do know in terms of evidence, but we have to take those back to our patients. We have to make them clinically relevant in practice when we have a patient sitting in the exam room with us. So how do we do that? And ultimately what we're trying to get at is this concept that we've talked about shared decision-making. So what is shared decision-making? It does rely on our clinical evidence. That's the framework. We have our evidence and our clinical experience that we bring into the room. As I think it was Drew who mentioned earlier, we all have kind of our sense, our gestalt of what's going to happen with a patient just based on our own experiences. And then we also have what the literature tells us. And then we have our patient, and our patient has their own values, their own contextual experience, their own things that they're bringing into the room, their own concerns and thoughts that we have to sit and listen to and incorporate in. And this is a really deliberate conversation. We can use encounter tools, we can use decision aids, we can do things to support that patient voice. And really what we're trying to get at is what we kind of refer to as an evidence-based patient preference. And I really like that. It doesn't say that we're only relying on one or the other, but it's really coming to an evidence-based patient preference. Because we also have a duty and a responsibility to help make sure our patients are making safe decisions. It's not fair to just say to the patient, oh, this is all up to you, right? We have to guide you. So it really blends the two together. And ultimately, that's our treatment decision. So we looked at this. We got support from a PDSA grant, which we were really thankful for, to conduct some focus group work, just to sit and talk with families who had been through this experience of choosing a second-line agent and really trying to identify with our patients what it was that they felt was part of that conversation or how involved they felt they were. And we did this with focus groups because we really wanted to engage patients in kind of talking about their experiences in the context of other patients, rather than doing just one-on-one interviews where you miss out on that engaged discussion. We talked to 24 patients, parents of patients. This was enough to reach what we call saturation, where we're starting to hear the same themes over and over again, and there's not really a need to engage more patients. These at all were parents of children who had failed a first-line therapy and needed to move on. In working with the PDSA, we were able to get national representation, which I think is really important, not to just make sure that you're doing focus groups on all patients of one particular physician. You really want that variety. And we were able to do this over Zoom, actually. So I think this is actually something that we can think about doing in other contexts, even internationally now that we've learned how to integrate Zoom into being able to communicate with each other. So we asked different questions. We asked treatment-related questions. We asked about information gathering, what sources people sought out. We asked about what other factors were important in influencing the decision. And really, it's a guided discussion. And we found there were three major themes. There was a theme of experience with treatment decision-making, factors that impacted decision-making, and then this concept of remission kept coming up with patients that we actually thought was very interesting. So this just shows some examples of the comments we got with treatment decision-making. Some patients really reflected that they were told this was our only option. We didn't really actually know we had options. Others felt it was a conversation, and it was really left up to them, for good or for bad, maybe, right? I mean, sometimes I think maybe patients do look to us for a little bit more guidance. There was a sense of trial and error. And we do hear this from patients that come to us and say, I feel like a guinea pig, or I feel like I'm just being explored on. It's just one drug after another. And if it doesn't work, you just kind of go on to the next drug, and how frustrating that can feel. We did talk about important factors. Obviously, these were pediatric patients, so school activities and having their child feel like a normal child at school and not having to sit out and not being isolated from peers. That was a big one. Some people were really focused on a particular platelet count that they had been told really mattered to be able to do those activities. There was a little bit of comfort, though, in knowing that there were always options, right? Kind of always having an open discussion about what's going to be next, knowing that there was never, this is it, there's always going to be something else that we can talk about. And then there was a lot of focus around side effects. And I always say we never want a drug to make you feel worse than actually living with the disease itself. That shouldn't be our goal. So really important to focus on. And then lastly, this concept of remission. And so we always think of remission as a positive word. We think about it as, oh, this is a goal, right? Every patient, this would be their ultimate goal. But a lot of patients, parents actually just reflected on us that it really doesn't feel like a relief. It feels like a waiting game, particularly when they've been through so many options, so many medicines. Remission truly doesn't relieve the concerns that we think it does. That term doesn't carry the same weight, maybe with a patient, that it does with us as a physician. So again, when we talk about clinical trials, when we talk about endpoints and words that we use, if they don't mean the same thing, then we're really not engaging in the right conversation. So in terms of patient experiences, there are factors that are important in decision making. They do appear to be rather consistent, but they didn't always feel like patient parents felt like they were critical decision makers. And the concept of remission may mean different things, and that's just one example of a term that we may be using, but we're not really cross-talking. And our clinician views may not be aligned with the patient experience, and that's why this shared decision-making and deliberate conversation is really important. So I do want to share, I brought them up here, but just again to highlight what's in your packets. This is a really great tool that's already been designed to help. It's more adult focused, but to help with this whole process. And then I really do love, this is my first time seeing this sheet, but just a guide to help, because these aren't just things that should happen with big, major critical decisions. This really should be every visit. Every visit I try to focus on, is there a reason that this isn't still the right decision, right? So just to highlight these two things that I think are really great, that you already have access to empower this process. And while this focused on pediatric ITP, I would argue, and second line therapy, I would argue this is relevant at any stage in ITP to any patient with ITP. So in conclusion, we really don't have randomized trials. You've heard this, and particularly in pediatrics, we're even more devoid of clinical trials. And so patient preference is a large driver. And how can we make this better? And I think this is really the platform for engaging in shared decision making. So thank you.